Hi, I'm Dr. Alexandra Filingeri, registered dietitian, doctor of clinical nutrition, and I'm sitting here with world-renowned plastic surgeon
Dr. Thomas Romo, a plastic surgeon in New York City. I'm here to introduce you to our new podcast, We Got Your Number.
We are here to break down evidence-based information and real-world experience, and we're going to bring in some of the top experts in the world because
We got your number. How can we improve diabetes treatment in this country?
let's bring in experts and really talk about what supplements actually
Can
help.
we improve our sleep health by using these medications?
How much protein do people really need to
Can
eat?
nutrition solve all of our problems?
What happens if someone comes off their weight loss medications?
Today we have Dr. Zinaria Williams, a colleague and transplant surgeon here in New York. I'm going to carry on we're going to talk about a few things here, Zinaria. I have an elective cosmetic surgery practice here in New York, and 75% of my patients are women. And every patient that I'm going to operate on, be it a facelift or a brow lift, or every single one of them say, I'm not going to lose any hair, am I? And so you and I have been contemplating and working on paradigms and sequences that we can develop to help women who are going into surgery. You're a surgeon, as a colleague of mine, and I of yours, and your specialty is hair transplantation with support pre-operative and post-operative. So tell us about hair transplantation, the process, how you do it, why you do it, and then how we're talking about the special things that we're setting up for patients with elective cosmetic surgery and hair restoration.
Yes. Well, I understand that why a woman would not want to lose one hair.
That's my wife.
Well, when I see patients, they have lost hair, and from a range of different causes. Most of the time it's androgenetic or female pattern hair loss. And the way that women thin is different than men. It's a different pattern. And so when a woman comes in and is showing me that this whorl right here that's always been a little thin but now is widening, or her center part is wider, her side part, her crown is more visible, they're different areas that in addition to maybe a diffuse loss. For men, there's a different pattern. There's the recession of these temples, a spot here in the vertex, and those go more into a bare, bald spot, so to speak, versus a diffuse thinning for women. So it's a very different pattern. So we approach it differently for surgery too. So for men, when they have a complaint of the corners, or that their hairline is receding, it's very obvious where we're going to put those follicular grafts. For women, because it can be a more diffuse loss, we have to have a conversation. Where can we put the grafts that would be the most significant for you cosmetically? And it can look like several different types of patterns. It could be a T pattern where we're doing the center part and the crown here. It could be the side part. It could be the other side part. It could be a wide headband. Different ways of approaching this condition, where working with women, they can be very flexible if you can give them something to work with. So we take the hair from the strongest area of the head, which is the back, mostly behind the ears. You'll see men who have receded hairline, and that back rim is the one that endures. For some reason, those hairs are not as sensitive to androgens as the rest. So those are your strong hairs.
Okay.
And whatever the hair is going to do in its original location is what it will do in its transplanted location. So if you move those most permanent hairs to the front, those become your permanent hairs now in the front of the hair, or the front of the head. So that's the process. There are two different ways of doing it. We have a conversation of what's the right way. We never shave women. I see sometimes women have shaved heads for hair transplant. I mean, that should be just outlawed. Because it takes a while to get back into normal life when most women have to shave their head and to achieve the length that they had. So our approach is a no-shave technique for women. For men, we've got some flexibility there.
How did the pattern change? Remember when hair transplants first started? Everybody looked like a doll. They were real. And then today, there's a whole different approach to that, isn't there?
Yes. So our grafts have gotten smaller and smaller. So the doll look, the pluggy look, is when the larger punches were used to take those groups of hair follicles. So maybe 4 millimeters or so of hair, of scalp, were taken out and then moved to the front. And putting those side by side gave it that kind of pluggy look because you've got little sprouts of hair going around. Now they are individual follicular units where you can have even a singular follicle that can be transferred over. Sometimes it's 2 or 3 follicles at a time. Those can be placed closer together. They can be manipulated in a way to strategically give more volume. For example, the 1 hair follicles will be put in the front line, and then the multiple hair follicles more in the center to add more density, or the illusion of density. Okay. So you can play around with it a lot more, and it's finer work. There are more follicles, more grafts than in the past, sometimes reaching 2,000 to 3,000, which is very different to the few hundred that was used prior.
And you remember they used to call them like corn rows or corn stalks. So like plants, and since we're talking about holistic approaches to managing surgical intervention that you're doing, do you do things preoperatively to the scalp or postoperatively to help the hair grow? Is there medication or herbs that you use?
We are starting to use more herbs to help get a patient more conditioned for surgery, and that does include hair growth. I think this formula that we're coming up with in this protocol could be used for, I think, a lot of different types of surgery for people recovering, but the one we're using does have some specific herbs that traditionally have been used for hair in traditional Chinese medicine. There's one called He Wu, and if you look at that herb or ask a Chinese medicine practitioner, you'll hear that it's used commonly to turn gray hairs black again. It would be, I think, in our language or our current way of speaking, a way of addressing the aging process. So it can help with returning that melanin into the hair and making it dark again, but also just making the hair more strong. But the way it does that, we know now, is by bringing in circulation and helping build blood. So that part probably wasn't recognized, but the outcome of how it was used traditionally was. So that is an ingredient in our preoperative formula, He Wu, mostly to help patients build blood, with the added benefit that it can help with hair growth as well. But we know that there's blood loss in surgery, and to help patients get all ready to a certain state before they undergo the knife, puts them in a better position going after.
Since I do elective facial surgery, I see patients have already had surgical intervention and had a facelift or a brow lift done, scarring, loss of hair. Are those good candidates for hair transplantation? And could the sequencing be changed where the transplantation is done towards the primary surgery that you and I have been talking about? And that whole foci. Can you talk a little bit about that?
There are certain cases where the hair transplant surgery is recommended to do first, and I think that's more for transgender women who immediately want to have a feminized hairline and don't want to necessarily wait to have the other surgery first, because that is a very significant defining feature. So oftentimes knowing that there may need to be a touch-up later, because if there's other additional surgery that happens that goes through the hairline, the scar can cause some of the follicles to be lost. A touch-up can be done later to the scar. But in that type of situation, I would counsel patients to consider doing the hair transplant first. In other cases, it makes sense to do it after, because then we can touch up any scar that is left from a facelift, or
Particularly like these forehead reductions that we've been doing.
yes,
And you modifying that
right.
hairline in the wound like that. So that's very innovative, and are working together, the synergies of offering lots of new approaches to hair and elective cosmetic surgery.
But Dr. Romo, this is one thing I would love to explore. So your patients don't want to lose a single hair.
Correct.
Sometimes you do have to remove skin, and that skin has hair.
Correct.
So what if we could save those hairs? So they've lost it in one way, but not really. So
Well, I think, and that's what you and I have been talking about this for the last 9 months now, is about doing a conjoint process where if hair-bearing skin has to be resected, can we keep those follicles alive, and how long we can keep them alive so that they can be utilized for restoration acutely.
Right.
And you're the expert on that.
well, it'll be something to explore. Either
Exactly.
something that can be done at the same time in
Correct.
another area of the scalp, or even if you're not coming down too far on the face, and eyebrows or other areas.
Exactly.
Or preserving them to be used later. That would be very exciting.
And that's we're going to be talking about that over this next year.
Yes.
One more thing I want to talk about is, from a medical point of view, we've talked about from a holistic and herbal point of view, but from more of a traditional medicine point of view, because you're actually an incredible expert in lots of these fields. The workup. I mean, there are metabolic and hormonal conditions like thyroid disease. I mean, these patients come in, and you've got to work them up as a physician, which you are, as a surgeon as well. But as a physician, what are the story on those kinds of medical evaluations?
Yes. So if somebody comes in with hair loss, maybe unexplained, they just notice a lot of shedding, there's a few things that we do. So first, I'll look at the scalp, see if I see any specific patterns that I can recognize that show this as androgenetic alopecia or a scarring inflammatory process. Sometimes that's not always clear, or sometimes that's not always clear cut. And then we have the conversation of your lifestyle. What is your diet like? What's your nutrition like? Have you had labs taken recently? What is your thyroid level? What is your vitamin D level? And even the reproductive hormones, if they know their testosterone level, or for women, their estrogen, it doesn't always correlate with the androgenetic loss. Sometimes it's just a sensitivity to high androgens that doesn't
Correct.
pan out into a lab result.
Correct.
But sometimes we do see abnormal lab results.
Meaning that the follicles, the hairs themselves, are sensitive to the hormone, and it's not an elevated level. It's just that they're sensitive to the hormone.
Right. And we see that a lot in the shifts that happen in cis women, where in menopause, you have a ratio shift of estrogen going down relative to the existing androgens. And so that's when that sensitivity could be more noticeable, and we start seeing the female pattern loss, and also postpartum loss. So postpartum can be telogen effluvium, which is a metabolic shock to the body, but also a sharp decrease in estrogen after delivery. And so there are some things we can tackle ahead of time and get on top of. So we have women who know that the last time they delivered, they had hair loss. So there are some treatments we can start beforehand. Or patients who are undergoing surgery and know that they lost hair because of telogen effluvium from the general anesthesia. I would love to be able to get those things addressed ahead of time so that people don't have to go through that. That would be one good idea.
Absolutely. Really great. Well, I don't want to not address the 800-pound gorilla in the room, which everyone's into right now, which is the GLP-1s.
Yeah.
People are, it's significant. Weight loss and that happening by taking those medications are improving the health, and the side effects that we're seeing from taking the GLP-1s from dementia and Alzheimer's to sleep apnea to cancers and this that, and the other. But it also has a stressing effect and an effect on the hair, doesn't it?
Yes, yes. So
Tell us about that.
When I see patients, and this is part of the workup where you're asking, I go through the medications. What are you on? What's changed in the last 3 to 6 months that could have caused this acute shedding of hair? And a lot of times we can track it back to something that happened that's causing a metabolic stress to the body. It could be surgery. It could be weight loss even without any medications. It could be a death in the family, a breakup. Medications, including the GLP-1, is one of the culprits that I see. And sometimes patients have put that together, sometimes they haven't. And when I ask them the story, it's like, yeah, actually I started losing hair about 3 months after I started one of the GLP-1 medications. And they lost a significant amount of weight. It's not necessarily the drug that's causing the hair loss, it's the effect of the drug. So the high weight loss can cause a metabolic stress on the body, leading to telogen effluvium, poor nutritional balance because the person is not eating as well. This is when a licensed dietitian comes into play, and I refer them for that. But it's a result of what's happening to the body. Even hormonal changes, you lose fat, your estrogen levels can go down. And so that all of these things can affect, but they're downstream of the medication that occur about 3 to 6 months down.
So in closing, it is, if you're having problems or concerns about hair loss, you really need to see a hair loss specialist, because like any qualified physician, you need to make a diagnosis before you come up with a treatment plan.
That's right.
And you, with the fund of knowledge that you have, your experience, there's many reasons why a person can lose hair. And you really want to get the correct diagnosis before you start going online and looking at a reel and buying a supplement,
Right.
Because you want to keep your hair.
Or going somewhere for surgery,
Correct.
quite honestly, because there are reasons to not do surgery for different types of hair
that's
loss.
why you need a qualified person like you, an MD, who is certified and specializing in hair, to come in and get a real evaluation to get set up a acute and long-term treatment plan.
Right. Yes.
So, Dr. Zinaria Williams, how do we find you if we want to get a hold of you and learn about our hair condition?
You can find me on Instagram at Zinaria Williams MD. You can also go to my website, which is zinariawilliamsmd.com. You can find our photographs before and after and more information on what we do specifically for hair at ungermedical.com. And if you want to see me in person, I'm in Manhattan.
Well, this has been fantastic. Thank you for your time today.
Thank you.